technology and humans are not substitutable. We have to think about how we make AI and other digital solutions part of the care team and then rearrange the care team to support this.
How should Medicaid and Medicare think differently about digital tools and remote care? Healthcare is changing rapidly, and technology is playing a bigger role than ever before. From remote monitoring and virtual care to artificial intelligence and digital therapeutics, new tools are reshaping how care is delivered, measured, and experienced. But as innovation accelerates, important questions remain. How do we ensure these technologies improve access rather than create new barriers? How do we build trust with patients? And what does digital transformation look like for community health centers? Today's guest is Jennifer Goldsack, CEO of the Digital Medicine Society, and one of the leading voices helping to shape the future of digital health. In this conversation, we'll explore the promise and the challenges of what digital medicine can do and what policymakers and providers often get wrong about technology adoption, and how community health centers can leverage innovation to improve care while keeping patients at the center of every decision. Jennifer, welcome to the podcast. Well, Jennifer, it is so great to have you with us today. I'm really excited for our conversation. And just to get us started, can you just introduce yourself and tell us a little bit about your work and your organization, and then we can dive into questions.
My name's Jen Goldsack. I'm the founder and CEO at an organization called the Digital Medicine Society, or affectionately known as DIME. And we essentially exist in the market to support those organizations and individuals who are doing hard things every day to make sure that as we digitize healthcare, the last big industry that really hasn't gone sort of whole scale digital at this point, we do so in a way that, one, returns to the patients that our industry actually exists to care for, and two, does so in a way that the healthcare industry that we sort of are privileged to expect today is actually sustainable into the future. And we are pretty unabashed about championing that double bottom line. That's the incentive structure within which we work. We want to make sure that the industry can go on to continue to care for patients into the future, and we will do everything possible to support that.
Amazing. So you've been at the center of digital medicine before most even people understood what that term meant. So what originally convinced you that this was the space that would fundamentally change healthcare?
Well, there's a long and a short version, so I might do you the privilege of sticking with the short version. So as you can tell from my accent, despite having been in the US for an unbelievable 17 years now, I did grow up with a very different health system, and it was quite surprising arriving here in the US and seeing how vastly different it was, how challenging it could be to access, the incentive structures, so on and so forth. But I've really had the privilege of working in healthcare since, the real leading edge of its initial digitization. So I started working in healthcare in the fall of 2008, having come over here actually as an athlete. So I competed in the 2008 Olympics for the US, actually, despite the accent. Thank you, Mum. She's American. Really had all the credentials of a researcher, and the fall of 2008 was a tough time to be getting a job. So ended up working in healthcare in Philadelphia, where I was. Penn was just about the only institution that was actually hiring. But the privilege of all of that was, 2009, high tech was passed. And so on the healthcare delivery side of the house, I was doing a lot of implementation science around these initial sort of digital tools, thinking about how we were going to be introducing them into workflows, what it would mean to actually create these capabilities in-house, generating new kinds of data. And that thread really has continued throughout my career. So was then on the clinical trial side of the house, went through a few different startups. And by the end of this, was absolutely convinced that if we wanted to actually have a healthcare system in the United States that was, one, sustainable, and two, cared for every single person, and I will say this multiple times, I'm sure, during our conversation today, that the industry exists to care for, we had to figure out how to harness these new streams of data, and we better make sure that these new tools in the toolbox were deployed within every inch of their capabilities to make sure that happens. And the vehicle for that was really a vision where we could bring together all of the different stakeholders, where we could break down the silos between individual health promotion, public health, healthcare delivery, medical research, because data isn't locked in a manila folder in a file cabinet anymore, and actually make sure that on our watch, we didn't actually blow what I think might be the last opportunity to ensure that our healthcare system is sustainable.
Oh my goodness, Jennifer, you're literally So I can just scratch the surface with my knowledge of this space. I literally say to myself, Amanda, you need to do more research in this. You need to spend more time in this. So I'm really grateful for the conversation, honestly. And before I even get into the next question about the real core of this, what were you competing in the Olympics? Because you can't throw something like that out there and then not tell us what it was about.
So I was a rower. I was in a 2-woman boat, which was absolutely phenomenal, out in Beijing in 2008. And it was a long time ago when they've hosted another Olympics in that city since then. But that did bring me over here to the US, and I did think I would stay for a year. Ended up staying, as I said, 17 years now to the good. And it's really interesting, though, because now as I look out at all of these wearables and things, and I don't have any, I remember all of the monitoring that we used to do when we were training. And so a lot of the principles are the same. I mean, we had literally a binder when we were on training camp or an Olympic year when we were sort of residents at the training center. And, you'd lie in bed in the morning and you'd have your 2 fingers on your jugular, right? And there was a happy spot between being able to take your heart rate without being shocked that you'd just woken up and not just falling straight back to sleep. And we recorded our heart rate every morning. And if, it was about where it should be, well, then you better go out and bust your ass all day. And if it was slightly elevated, then, you might work with a physiologist and the coach to ease off a little bit. And if it was through the roof, you turned over and went straight back to bed. And we'd weigh ourselves, and, we got stabbed in the ear to get all of our, lactate readings during workouts. And it's really interesting that this notion of monitoring isn't necessarily new, but the burden of getting all of this data, which can have huge impact on health and performance, is something that I've been aware of for a long time. So it's interesting how all of these different sort of careers that I've been privileged enough to have are converging.
Well, and just that they've come full circle, it's sort of, but kudos, because that is not an easy sport. And so that's amazing.
Well, my back still hurts as I sit here and talk to you, but, it's, I do it again.
I can imagine. What an incredible experience. And like I said, informative in an interesting way. It really did sort of, that seems like it was the early part of, what kind of led you into the space in a way, or at least that you can connect what you're doing now back to what was going on then. But another question for you, when you think about digital health today, what excites you most, and then what worries you the most?
I'm really not overstating it. It's not a sort of hyperbolic statement when I say I really do think that the flows of data that we are generating inside and now in particular outside of the clinic, and our ability to run the sort of powerful compute on them that we've never had at our fingertips before, so that in almost real time, these signals in the data are clinically interpretable. And we can couple that with communication technology, which will allow us to overcome the maldistribution of, clinical experts and the patients who need them the most. Like, that's really exciting to me. And I think that we can truly sort of achieve what's become a bit of a bumper sticker that, let's actually do healthcare, not sick care, that we can really do health promotion. And in doing so, get better outcomes at a cost that individuals and society can afford, and most importantly, improve access. I believe all of those things to be true and possible, which also means, and this gets to the bit that worries me, that it's up to us to make sure that we actually capture that outcome. And what worries me the most, and, I'm sure we'll go on and talk about sort of, equity and access and costs and all of these sorts of things. But what actually worries me most in the short term is when I look at the checks that are being written into this new generation, primarily of AI-enabled products. When I look at the determination of the federal government to create the infrastructure for us to capture these benefits, I think there's a pretty fleeting window where we actually have to realize a lot of the benefits, or there's going to be frustration, disappointment, and people will turn away and we will miss this opportunity. And so for me, one of the greatest risks is we don't get a couple of bites of the cherry here. And one of the things we think about at Dime all the time is we have to build it right out of the gates the first time. And we have to make sure that when we roll out these solutions, when we think about re-engineering workflows, when we think about incentives, when we think about the necessary infrastructure, guardrails, incentives, that we do so in a way that actually works for everyone out of the gates. Because the example that I'll always use is that we can look at something like insulin, right? There was a little boy up in Canada who I think just over 100 years ago was the first,
Yep.
juvenile diabetes, starving to death, the first human to receive insulin, and just fundamentally changed the trajectory of a pretty awful disease. But the United States is still on a human rights watch list because 1 in 4 individuals with diabetes ration their insulin because they can't afford it. We don't go back with pioneering technologies and make sure that we bring everyone with us. I hear all of this talk about, there's the consumerization, and then we're going to do this in these populations, and then we'll go back and make it work for everyone. No, we won't. We've got 100 years of data that tell us that we won't. So we take very seriously the imperative to capture this opportunity and to make sure we capture it for everyone.
How do you, taking us off a little bit, but I'm just curious, in your work, because when you're talking about, efficiency and improving workflows and just like the application of AI to enhance all of these things, how do you ensure the balance? I guess, like, where do the folks on the ground play a role in how to design and create an intervention that really is both optimizing but realistic? You know what I mean? Like, sometimes I'm just curious, like, how do you integrate sort of I don't know if you would call it the consumer or the user, I guess, in this case, into the design and sort of the proposed interventions into the space? It's
a really good question. And I think that it's one that is incredibly difficult to answer. Ultimately, the greatest solutions and the greatest success are going to be driven by those individuals, whether it's patients, care partners, practicing clinicians, administrators who really see and live the difficulties of either delivering healthcare or being a patient or a care partner every single day. They are going to be able to tell you the pain points. They're going to be able to tell you what would be an acceptable alternative. That information is absolutely critical. At the same time, I also don't think we need to be applying additional burden to these stakeholders to figure out the problem, because they show up every day, again, whether it's a care partner or whether it's a clinician or whether it's a patient trying to quarterback their own healthcare, holding the system together with, duct tape gloves and, their fingernails. It is so hard right now. And I think there's a little bit, my personal opinion, where on those occasions where we look to engage health systems, clinics, or individuals, that we do so in a way that's actually quite burdensome, instead of being curious about learning about the problem from the innovator side before going out and building a solution.
Yeah.
And so, plus, and this is where I always sort of pause, because I never want this to be misinterpreted to say that there's some, tech guru out there who, is going to blow up healthcare and make it better for all of us. I don't believe that's the case. But, there's also the notion of not wanting to invest hundreds of billions of dollars in a powerful technology, the likes of which we haven't seen before, only to get faster horses.
Right.
And I think that there does need to be both close attention paid to the individuals that define, characterize, and in fact, the individuals our system, exists to serve, and the ability to peer around the corner to a future that is actually fundamentally different to what we have today. So to answer your question, which would be useful, I think it's a combination. I think we need to be paying close attention to what are the most pressing challenges we need to solve for. I think we need to be very careful not to approach the problem with a very sort of like paternalistic and tech deterministic approach. And yet we have to be open to saying what we have doesn't work. Mm-hmm. It may be effective on a day-to-day basis, but my goodness, it's thanks to the hard work, the dedication, and the unsustainable commitment of the individuals within the system. And I think we have to be comfortable to look for something different without blowing up what we have and what we rely on a day-to-day basis. And in my sort of opening comment said, I've been lucky enough to be in this since the start. And the positive thing here is, when I think about the early days of EHRs, there were none of these multi-stakeholder conversations. Like, this moment feels fundamentally different. It is moving so much more quickly, but there is enormous dialogue across different stakeholders, folks with different incentives, folks who have never participated in the healthcare system before, that does feel fundamentally different to the sort of initial introduction of EHRs. And that makes me really positive.
Well, I wonder, and I'll sort of toss this out there, health centers, we're the largest network of primary care providers in the country. And we're in every state, and we're, it's primarily serving underserved populations, be that rural or urban. But I do feel quite, I know many, many health centers and individuals at health centers, both clinicians, but also, in the IT space, in the operational space, you name it, are, participating in the development of a lot of different tools already sort of being used, but also sort of like being updated, et cetera, et cetera. But I would say, because it is such an enormous part of the reality day to day today, but it's only going to continue, I feel quite confident in saying that, health centers are both well positioned, but also I think very willing to participate. And so I kind of offer that up as sort of in the work that you're doing, if there's interest and opportunity and value in engaging, like you said, the different stakeholders. I know health centers, they play a unique role, again, one, because I think of how widespread they are and just being the largest network of primary care providers, but also the complexity of the populations that they're seeing. And because of their care model, because it's, you're looking at a whole person approach. And so it's primary, it's mental, behavioral, it's dental, it's vision, it's, substance use, it's literally everything. And so anyway, I could talk about that for hours, but something to kind of put a pin in, if there is ever a time, Jennifer, where there is a need to convene or pull in different types of stakeholders to be supportive, I feel confident in saying I know health centers would jump at the chance. But I think, sorry, go ahead.
Yeah, I was going to say that's wonderful. And as you share that and you talk about the commitment and the willingness, it doesn't surprise me at all, because I think the tools that we have here, if we can't figure out how to use them to improve the way we care for people and make it more sustainable for those folks who are responsible for that caregiving, then I would imagine that health centers, probably more than most care sites, recognize that we have to do this differently. Yeah. And I applaud your community, and I applaud all of the health centers for being willing to say, we will do extra work in the short term to actually make sure that we are part of ensuring that we get this right into the future. And that's actually quite a lovely reflection.
Thank you. I mean, I think you kind of started to talk about this, and I think we're going to get into it too, is just it also comes down to equity. I think part of that commitment is so deeply foundational to the health center mission, and part of it has to do with making sure that there is equitable access to care, and that includes the technology, especially for underserved populations, where it's sort of like, in some ways they need it more than anyone, and at the same time they're also in some cases the most challenged in terms of accessing the technology to help, whether it's creating access or improved outcomes, wearables, you name it. And some of that has to, it depends if we're talking urban or rural, but some of it is just connectivity. You look at rural America, and it's, there are many, 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 many communities where just simple broadband is not, it's not an accessible thing. And so, there's a lot of work to do in the space, of course, no matter what angle you're looking at. But I do think that health centers are very willing participants, both because of mission, but also because, to your point, they know they have to get it right. And so if they can take an active role in helping to get it right, they're always willing to step up. But one of the other questions I was going to ask you is, do you think that healthcare is moving fast enough technologically, or too fast without enough guardrails? Because that is a conversation I think that comes up a lot, especially in the context of AI, that it's happening so rapidly that there's questions around like quality control, so would love your thoughts on that.
There are two terms of phrases that I really like. So the first is that innovation moves at the speed of trust, and the other one is innovation moves at the speed of desperation. And face value, those two statements feel very different. But I actually think trust is a lot more utilitarian than perhaps we give it credit for. The silly example I'll always use is I don't have a particular trust in my bank and that they're good actors and they're not doing this, that, and the other. But deeply trust the banking regulations and that they're probably afraid of doing anything nefarious. And also, if you think I'm taking 2 hours out from my busy workday to go stand in line at a branch during its very, very limited weekday hours to do simple tasks, you're out of your mind. And so I'm going to use the app because trust in that product and that service is very utilitarian. And, I don't mean to sort of belittle the sort of elements in healthcare there, but it's a bit like, Schrodinger's speed, it's both too fast and too slow all at once, right? We need help. We need innovation. We need to do things fundamentally different. We need to create access pathways. We need to create, much more affordable systems. We need to create systems that everyone can access, so on and so forth. And we need it yesterday. And yet at the same time, these tools are so powerful and they're moving so quickly that there's a very talented, truly, anyone who works as a clinician, whatever their role is whip smart. And we rely on that for every decision. And yet this is an entirely new generation of technology that these super smart people are still not yet fully comfortable with. And so, how do we balance that? And that's something we think about all of the time. We've already created an awful lot of open access resources to help folks at settings of all different sort of ilks across the country, really think about what's the maturity of our organization, what's the opportunity, what's the unmet need, how do we think about prioritization. And we really like this notion here at Dime, what we describe as stackable wins, which is starting with something that is right size, that is low risk, but is still going to return value, start to get comfortable, start to build that muscle there, and then continue to pile on innovation, solutions, new approaches that advance the goals and the priorities of the center or the practice or the system. Because the other thing is these tools and technologies shouldn't have their own set of priorities. They are simply tools in the toolbox that should be deployed thoughtfully in pursuit of the overall goal.
I appreciate you saying that and putting a finer tune to it, because I think that gets lost. I think a lot of people are just, go, and this is a new tool, and this, you need to optimize and you need to get there, and that is completely forgotten. It's sort of like, no, this has to be in sync with your priorities. It has to be in sync with what you're trying to do. And that sometimes requires slowing down long enough to just make sure that there's alignment.
Absolutely. And perhaps it's a little bit Pollyanna, but one of the hopes that I hold a lot about this moment of technological innovation is it's actually going to force clarity in that thinking, right? If your board and your leadership team at the center can't articulate, what are our priorities? What are our goals this year, in 3 years, in 5 years? And, frighteningly, which I think is why we need to do things differently, the 5-year time frame can be too frightening to even think about. So what are our priorities this year? What are our priorities in the next 3 years? And then, what are the tools that we can use for the job? That's actually a wonderful forcing function and could do great things in terms of the impact of the technology.
Yeah, 100%. So, we talked about this a little bit, but I do want to lean into it. So we were talking about, or I mentioned that health centers are often the most medically complex and underserved populations. So how can digital medicine improve care without deepening inequities?
The kind of flippant response, and I really want you to hold me to task if it's a bridge too far, is, how much more could we deepen it? The reality is the inequities that we face in health and healthcare as a nation, which due to a variety of policies that are being implemented are only going to continue to get worse. It forces me to ask a different question when I reflect on and when I think about our strategies and when I work with our partners here at Dime, which is instead of, oh gosh, should we, what about inequities? But more, how do we use these tools to make sure that we are actually ameliorating the rampant inequities that exist in healthcare? And how do we think about making sure that the solutions that we're building are actually optimized for the most vulnerable, where we have the greatest unmet need, and where, in lockstep with that, perhaps the lowest resources and the greatest complexity. So, I'm thrilled to hear that your community is so open to this, because I think that will force what we would describe as principles of universal design, which is you design for the most challenging and complex environment. And once you do that well and you do it in a way that's low friction, that actually works, well, then gosh, it's going to work for everyone. So if we can really work with centers to understand what those needs are, that's an opportunity. And I think the other thing I like a lot about these sort of this generation of digital technologies in healthcare is technology by definition is very easy to modularize, right? We can actually make almost bespoke tweaks for every individual or every practice. And so what we've sort of done over recent decades of healthcare is, every set of guidelines, every set of best practices is based on an average of the country that we absolutely know is not an average. It's, a sort of reflection on a set of data that is usually a privileged few that don't look like the majority of people and individuals who receive healthcare in the United States. Now with, data that we can access and use and reuse with the appropriate permissions, with this powerful compute power sitting on top of it, we can make much more personalized and proactive decisions. And frankly, that has the greatest value to offer underserved and complex populations. And they can be personalized. And, we're not supposed to talk about equity anymore, but we do endlessly at Dime because we believe in it as a value. But truly personalized healthcare is the most equitable care that exists, because it is healthcare that is designed for you, not a group of people that we lump you into, not a sort of average where the sample didn't include a single person that looks like you. Truly personalized care is the most equitable care. And I think about all of the toggles that we can use. You talked about connectivity. There are definitely some tools that are going to require a good amount of connectivity. But when I think about things like remote monitoring or communication, all of this can be done with tiny, tiny data packages, right? We can run it off 2G. It's been proven. We just need to design it, and we need to demand that those tools look like that. Not everything has to be conducted on a video visit like this. There's a thing in the kitchen that a lot of people still have hanging off the wall called a telephone. That works too. You can do a simple SMS. Tons of data behind all of this, and we need to be open-minded to it. So, to me, the question that we need to ask ourselves, and perhaps the values that we need to hold ourselves to, are making sure that as we develop and then deploy these tools, they are done in such a way that they offer value to the patients who can benefit the most, to the centers and to the sites of practice that can benefit the most, instead of holding ourselves back by asking, what about equity? Because if we can't make these tools work for everyone, the equity is only going to continue to get worse anyway.
Yeah, I appreciate that lens. And I think it is really important. And that's another one that I hear very rarely, where it's sort of like, no, this is a game changer in terms of really addressing the inequities from person to person, not just like population based. I think there's another layer to this, Jennifer, around, I think for health centers, because they are severely under-resourced in terms of like the investment that should be made, considering the amount of work that they do and the outsized impact they have on both savings to the system and improved health outcomes for their patients. But I think the other worry and just reality for so many of them is that the commitment, the intent, and the understanding, the recognition of the vital importance of this is very much there. But the resources to acquire and the resources to participate is one of the biggest challenges. And, because we're talking about underserved populations and underserved communities, they're not always at the top of the list in terms of where dollars are going to flow. That's just the reality. And so that's a whole other part of the equation where it's sort of like, and it's interesting, maybe at a, we can talk about it now, but maybe a deeper conversation around like what role can health centers play in the sort of development and the sort of stakeholder component, which may or may not plug them into the tools, in some facet. I don't know, but I think that's another part of the equity conversation that I think health centers, that is just their reality. And I don't have a solution for that. I think there's some amount of investment coming through the Rural Health Transformation Fund to move in that direction, but that's a drop in the bucket compared to, what needs to happen. But,
I agree with you. I think the Rural Health Transformation Program is great, and, the funds it's wonderful that they exist, but I think back to the funds that were administered during COVID, that single check, that's, one-time sort of bolus, and it doesn't persist. And, the shortfall that is faced quarter over quarter, year over year, the complexity, the challenges, the rising costs are not going to be fully offset by that. And also, there's a lot of underserved areas that aren't rural. So, there's myriad challenges here. But one of the things, interestingly, that I talk to the big tech innovators about all the time is really trying to encourage them to come in and support, send everyone, all of the centers in your community, because the slightly sort of punchy question I'll ask of them is, how do you think you are going to get enough ROI on the investments that you are making to really actually make this a $5.3 trillion market? You should be able to make it work, but you won't unless you capture the whole market, because the investments that you are making now are so large. You have to make sure that this is not just going to be a set of very expensive, very energy, very cost, very data, sort of greedy resources that work only for academic medical centers. That is not a big enough market for you to be successful. You have to be a proactive actor in making sure that every single site of care can benefit from these tools and technologies. Otherwise, I will literally use these words, like your total addressable market will not be big enough. The policy changes will not persist because they are not going to be well received by everyone. Get smart, go out there, support the market. And I am always pleasantly sort of surprised by the reaction that our sort of tech innovator and investor colleagues actually have in response to that. They have to make the market if they want to capture it. And I believe there's a lot of good that can be captured, that double bottom line I mentioned, for patients, for sites of care, and for the folks making the investment. And I think that's something that I would love to see centers in your community being identified as a stakeholder group that would be wonderful partners to these tech companies who I'm encouraging to do this kind of investment and outreach.
Amen to that. I'm on board 100%. We'll do a follow-up after this conversation, because I love that, and I appreciate you saying that and recognizing it. I'm conscious of time because I know you have a stop coming up here. So a couple more questions. How do you think safety net providers should be thinking differently about implementing digital tools compared to larger health systems?
I'm not sure that they should be thinking differently. I think it's unfortunate that they face more pressure and more constraint of not having enough wiggle room to fail fast, right? Yeah. They have to get it right. The dollars are so constrained. Energy, if you like, of the teams are so dedicated to maintaining sort of patient care that works. Implementations and innovations that support the needs of your community, the goals of the systems are paramount, should be paramount, just like they, should be at the Mayo Clinics of the world. But the degrees of freedom, I think, in the decisioning are smaller. And I would strongly encourage this notion of stackable wins. Look for opportunities where we have proven success stories. We try at Dime and share an awful lot of sort of tales from the trenches to try and highlight shovel-ready solutions, best practices, trustworthy partners that you can get going with. Don't be afraid of it, but I also think the fastest way to kill it, I'm full of like idioms today, the fastest way to kill a good thing is to overreach. Yeah. What can we do today? What can we learn within our risk parameters? How do we assess value? Great, now we're starting to build a muscle, let's go again, let's go again, let's go again. And so that would be more of the sort of tactical approach that I would advocate for, though I maintain that the strategies should actually look quite similar.
Yeah, I agree. I think I totally agree with you. Some of it is just scale, but and then resource constraints, like you said. One other question for you. How should Medicaid and Medicare think differently about digital tools and remote care?
Well, fortunately for you, I've only got, I'm so sorry, the dog's coughing.
You're fine.
Digital in and of itself is not a silver bullet. And I say this as a woman who founded and runs an organization called the Digital Medicine Society. We have an obesity crisis in the United States, yet I suspect the majority of households in America have a bathroom scale. Simply having some data
Yep.
Doesn't make any difference whatsoever. We have to have data in context. We have to have support. We have to have intentionality. We have to be able to move in moments of context. And that usually requires human intervention, and we can sort of couple with AI with that, and I think that will be enormously effective. But simply throwing extra data at the problem is not going to solve anything. I think second, I believe that we are going to be able to substantially unburden the clinical workforce, create job descriptions that actually bring back the joy of medicine to everyone who practices it, regardless of their qualification, be able to extend the capacity of the clinical experts that so many people are so desperate for and can't access. But technology and humans are not substitutable. We have to think about how we make AI and other digital solutions part of the care team, and then rearrange the care team to support this. And I think in terms of reimbursement, of incentives, of infrastructure, of training resources, we need Medicare and Medicaid to come in and support that. I also think that we will only ever get so far when we have such a dominant fee-for-service environment, because otherwise we are simply continuing to incentivize services, and we won't look to services by qualified healthcare providers. We aren't going to be more expansive in thinking about different members of the care team. We aren't going to think about moving care upstream to think a little bit more about prevention and management rather than sort of downstream, expensive cures that are burdensome, don't always have the best outcomes, so on and so forth. So I would say that those would be the three pieces. Data and a smartwatch or whatever was being bandied about for one idea at one point for everyone is not just going to solve the problem. It needs to be part of the stack. We need to think about digital and technology as part of the care team, not as direct substitutes, and we need to think about new incentives and new payment pathways to really capture the full value of these tools.
Yeah, I totally agree. So last question for you. What is the best thing that health centers can be doing right now? Like, if you had any advice for them just in sort of where we are in the process and sort of what's coming, and, in as much as you can predict, looking further down, what is the best thing that health centers can be doing right now to ensure that they're not just at the table, but they're, engaged properly and doing the best that they can for their patients, their communities, all of it?
The individuals who know what is best for their patients sit within the centers. And I don't think that anyone with decision-making and budget allocation responsibility should feel pressured by what they see in the news, by sort of numbers they see being sort of bandied around, to act in ways that they don't yet feel confident will return to their patients and sustain their missions. There are plenty of opportunities, but I don't think anyone should feel rushed or that they're doing anyone a disservice by not diving in. I think being very intentional about the solutions that you introduce, really tracking those success stories, sharing them across centers so that every single center doesn't have to go it alone. All of that is going to be incredibly powerful. And, you and the community continuing to give voice that centers are a home for not only the patients who can benefit from the digitization of healthcare the most, but are staffed by passionate experts who are willing to put their shoulder to the grindstone to build this future, one that sustains for their center and their patients. I think more stakeholders across the country, whether it's at payer organizations, whether it's at, investor shops, whether it's at, tech companies, need to be aware of that mindset, because the innovators are seeking partners right now. They're seeking partners who can frankly help them capture the greatest ROI. And I would love to see centers' voices better reflected in those conversations.
I love it. Well, we have lots to catch up on after this conversation. So, but Jennifer, thank you so much for the work that you're doing and for being with us today. Would love to have you back because this is going to continue to unfold. And I know you guys are doing such incredibly valuable work in this space, but just really appreciate the time today and the conversation. And I can't wait to catch up on some of the things that we talked about in an offline conversation to figure out how we can be more supportive and get plugged in. But thank you so much.
Fantastic. We've got a nice punch list of things to follow up on, and thank you and all of the centers for your just relentless commitment to patient care. And our responsibility at Dime is to make sure that these tools are developed in such a way that they truly help. So thank you.
Amazing. Enjoy. Thank you so much. Jennifer, thank you so much for joining us and sharing your insights. One of the biggest takeaways from today's conversation is that technology alone isn't the answer. The real opportunity lies in using digital tools to strengthen relationships, expand access, and improve outcomes for patients and communities. For community health centers, the challenge isn't whether digital medicine will help shape the future of care. It's how to ensure that the future is accessible and centered on the people we serve. Thank you for listening to Community Health Centers Unfiltered. If you enjoyed this episode, be sure to subscribe, share it with a colleague, and join us next time as we continue exploring the ideas and innovations shaping the future of community health centers. Until next time, thanks for listening.